So, after having said about the various symptoms of dysautonomia, now let me take up the individual system, what will be the manifestation and as well as what will be the treatment. So, if you take the involvement of the gastrointestinal system, the gastrointestinal manifestations will be in the form of nausea, then followed by that vomiting, and these individuals, they'll have postprandial fullness. So even minimal amount of the food they take, immediately they'll have that particular fullness. That is called as that is called as postprandial fullness. And apart from that, these individuals, they also have the features similar to that of GERD, that is reflux. Reflux of the food or dysphagia. Okay, so these are some of the gastrointestinal manifestations. Apart from that, the manifestations related to gastrointestinal motility, and those manifestations related to the gastrointestinal motility, they include constipation. The individual will have either constipation or diarrhea, So either of these can be there in case of the autonomic neuropathy. And in certain group of individuals, they also have fecal incontinence. So these are the gastrointestinal manifestations. And particularly you take in case of type 1 diabetics, gastroparesis is very common. Gastroparesis in the sense there will be decrease in the gastrointestinal motility. Okay, so gastroparesis gastroparesis should be considered in type 1 diabetes mellitus patients, and these patients with diabetes mellitus, that too uncontrolled diabetes mellitus, these autonomic neuropathy is very common, and that will manifest in the form of the gastroparesis. Now, what will be the treatment of this diabetic gastroparesis? So the treatment is that, so basically in gastroparesis there is decrease in gastrointestinal motility. So you need to improve or you need to increase the gastrointestinal motility. And how is that you can increase the gastrointestinal motility? That is by giving prokinetic drugs. And the example of this particular prokinetic drug will be metoclopramide. That will be metoclopramide. So this particular metoclopramide, you need to know the dosages of this metoclopramide. Okay, so this metoclopramide has been of some help in treating diabetic gastroparesis. It is given in a dose of 10 milligrams. It is given in a dose of 10 milligrams, and the route of administration is the oral route of administration, and this is given thrice daily or 4 times daily. So it is given 3 times or 4 times per day. That is about your metoclopramide. And when should you give this metoclopramide? This metoclopramide should be given 30 minutes before the meals. right? 30 minutes before the food intake, you need to give this metoclopramide. Now, what are the adverse effects which are associated with the metoclopramide? So the adverse effects which are associated with the metoclopramide include drowsiness, followed by that there can be development of restlessness, there can be development of fatigue and lassitude. These are the common adverse effects associated with the metoclopramide, right? So this will be the treatment of the diabetic gastroparesis. So adverse effects already I have discussed, that is drowsiness, restlessness, and as well as the fatigue. Now apart from that, few more adverse effects associated with the metoclopramide include tardive dyskinesia and extrapyramidal side effects. Right, tardive dyskinesia and as well as extrapyramidal side effects. So these are some other adverse effects associated with the metoclopramide, but these adverse effects are seen when the metoclopramide is used for longer duration. That means when it is used for more than 3 months, right, when it is used for more than 3 months, then this tardive dyskinesia and as well as the extrapyramidal side effects are being seen. Now, what do you understand by this word tardive dyskinesia? See, tardive dyskinesia is that where the individual will have involuntary jerky movements. Right, and this involuntary jerky movements, they occur throughout the body and even they occur within the face as well. That is what is your tardive dyskinesia. So long-term adverse effects include tardive dyskinesia and as well as the extrapyramidal effects, whereas the short-term adverse effects include drowsiness, restlessness, and as well as the fatigue. Now followed by that, you need to know another important drug, that is erythromycin. See, this erythromycin appears to bind to the motilin receptors which are present within the stomach. So this erythromycin, it binds to motilin receptors which are present in the stomach. And this particular erythromycin has been found to improve the gastric emptying. By binding to the motilin receptors, they will stimulate, or this particular erythromycin will stimulate the gastric emptying. So this erythromycin, it has been found to improve gastric emptying over a short-term doses in 250 milligrams thrice daily. So what is the dosage of this erythromycin? 250 milligrams, and you have to give it 3 times daily. But as the time progresses, the efficacy of this erythromycin reduces. That is what is your erythromycin. So erythromycin, it binds to the motilin receptors in the stomach and it has been found to improve the gastric emptying over a short term in doses of 250 milligrams 3 times daily. But the efficacy of this erythromycin diminishes over the time. And in selected patients, injections of botulinum toxin into the pylorus can reduce the pyloric sphincter resistance, and that will also enhance the gastric emptying. Okay, so the other drug is botulinum injection. Right, this particular botulinum injection, that we call it as Botox, it is injected into the pylorus of the stomach. Now as it is injected, right, as it is injected into the pylorus of the stomach, that can reduce right, that can reduce the pylorus sphincter resistance. Right, that will reduce the pylorus sphincter resistance. Now, as it reduces the pylorus sphincter resistance, it will enhance the gastric emptying. Right, it will enhance the gastric emptying. So that is what is the action of your botulinum injection. So the drugs which will improve the gastrointestinal motility are metoclopramide, erythromycin, and as well as the injections of the botulinum toxin. And if you take an intervention, we have an intervention called as the gastric electrical stimulation. Gastric electrical stimulation has been reported to improve the symptoms and quality of life indices in patients with gastroparesis refractory to pharmacological therapy. So, even this has found to improve the symptoms of gastric emptying. But in which group of individuals you need to do this gastric electrical stimulation is, that is in those individuals who are refractory to, right, who are refractory to pharmacological therapy. Right, who are refractory to pharmacological therapy, in them you need to do this gastric electrical stimulation. So that is about the treatment of diabetic gastroparesis. Then followed by that, how do you treat diarrhea associated with autonomic neuropathy? Diarrhea associated with autonomic neuropathy has occasionally responded to broad spectrum antibiotic therapy. Okay, so this diarrhea you have to treat that with right, you have to treat with broad spectrum antibiotic therapy. And what will be that broad spectrum antibiotic therapy? That includes rifaximin, then metronidazole, right, which is an antiparasitic drug, then combination of amoxicillin plus clavulinate, then the other important drug is quinolones, that is ciprofloxacin, then followed by that doxycycline. Okay, so these are the antibiotic therapy that can be given for the treatment of diarrhea associated with autonomic neuropathy. Sometimes this diarrhea can undergo spontaneous remission, but this antibiotic therapy also will help. And refractory diabetic diarrhea, it is often associated with impaired sphincter control. Right, it is often associated with impaired sphincter control, and thereby there will be fecal incontinence. Right, so there can be refractory diarrhea, and this particular refractory diarrhea, it is associated with, and that is due to impaired right, impaired sphincter control, and this impaired sphincter control will cause right, will cause the fecal incontinence. That is the reason why you have the refractory diabetic diarrhea. Now, then followed by that, apart from antibiotic therapy, the other group of drugs that can be given for the treatment of diarrhea is you need to give anti-motility drugs. And these anti-motility drugs include loperamide. And this loperamide, it is given at a dosage of 4 to 8 milligrams daily. Or you can give difenoxylate with atropine. Right, difenoxylate with atropine. So this is another combination which can be given to reduce the gastrointestinal motility. And this difenoxylate plus atropine, it should be given 2 tablets up to 4 times a day. Right, 2 tablets up to 4 times a day. That will provide the relief within the individual. In severe cases, right, in more severe cases, you need to give codeine. Codeine, it is an antitussive drug, and the dosage of this particular codeine is 60 milligrams tablet. And this particular codeine, this is given to reduce the frequency of the diarrhea. Right, so this will reduce, right, this will reduce the frequency of diarrhea. And not only it will reduce the frequency of diarrhea, and it will also improve the consistency of the stools. That is about your codeine sulfate. Then followed by that we have clonidine. Clonidine, it is centrally acting alpha-2 sympatholytic drug. And this particular clonidine has been reported to lessen the diabetic diarrhea. Right, it will reduce the diabetic diarrhea. Okay, so that is about your clonidine, which is a centrally acting alpha-2 sympatholytic drug. And this clonidine, the usage of the clonidine is limited by its tendency to lower the blood pressure in these patients who already have autonomic neuropathy. Because in autonomic neuropathy, these patients, they develop orthostatic hypotension. And even this particular clonidine, it is also associated with orthostatic hypotension. So that is the reason why the usage of the clonidine is being limited. So that is about the treatment of diarrhea. So to summarize the treatment of diarrhea, these patients, they have to be given broad spectrum antibiotics such as rifaximin, metronidazole, amoxicillin, clavulanate, ciprofloxacin or doxycycline. This is one method by which diarrhea associated with autonomic neuropathy can be controlled. And in certain group of individuals, you have refractory diabetic diarrhea. And why is that due to? That is due to impaired sphincter control and fecal incontinence. And if it is a non-infectious diarrhea, like in case of autonomic neuropathy, you can also give anti-motility drugs. And these anti-motility drugs include loperamide 4 to 8 milligrams daily or difenoxylate with atropine 2 tablets up to 4 times a day. That will also provide the relief. And whenever there is severe form of diarrhea, you need to give codeine. That is 60 milligrams tablets may be required to reduce the frequency of diarrhea, and it will improve the consistency of the stools. And clonidine is another antihypertensive drug. It is a centrally acting alpha-2 sympatholytic drug that has been reported to reduce the diabetic diarrhea. But its usefulness is limited because it is associated with the development of orthostatic hypotension. Already in patients with autonomic neuropathy, they have the problem of orthostatic hypotension, and if you give clonidine, that will further precipitate this orthostatic hypotension. Now, followed by that, Treatment of constipation associated with autonomic neuropathy. Constipation usually respond to a stimulant laxative. Right? It responds to stimulant laxatives such as senna. Okay, so with the help of this, the constipation which is associated with the autonomic neuropathy can be reduced. Now, these patients with autonomic neuropathy, they also have the problem of the bladder abnormalities. So, what is that bladder abnormality? That bladder abnormality is in the form of incomplete emptying of the bladder. Right, that bladder abnormalities, it is in the form of incomplete emptying of the bladder. This incomplete emptying of the bladder can occur sometimes. So, how do you treat this incomplete emptying of the bladder? So, you need to improve the emptying. For that, you need to give bethanacol. So, this bethanacol, it is given at a dosage of 10 to 50 milligrams. The route of administration will be the oral route of administration, and how many times it is given? It is given 3 times a day. And this bethanacol, it is found to improve the emptying of atonic urinary bladder. That is about your bethanacol. And the other modality by which you can improve the bladder emptying is the catheter decompression. Right, catheter decompression. So catheter decompression of the distended bladder has been reported to improve its function, and considerable benefit has been reported after surgical severing of interval vesicle sphincter. So basically, catheter decompression should be done in case of a distended bladder. Right, in case of a distended bladder. So this has been reported to improve the function of that particular distended bladder when you do a catheter decompression. So that is about the treatment of the bladder abnormalities. And these patients with autonomic neuropathy, they are associated with the development of the orthostatic hypotension. And how do you define this orthostatic hypotension? When individual is in supine position, from supine position, once the individual attains either standing or sitting position, right? Once the individual changes the position from supine to standing position, there will be fall in the blood pressure of the individual. And how much will be fall in the blood pressure of the individual? Systolic blood pressure will fall more than 20 millimeters of mercury, and diastolic blood pressure will fall more than 10 millimeters of mercury. Right, that is after 1 to 3 minutes of standing. Right, from supine position, once the individual attain the standing position, after 1 to 3 minutes, you measure the blood pressure. If the systolic blood pressure falls more than 20 and diastolic falls more than 10, that we call it as orthostatic hypotension. And what will be the initial treatment of the orthostatic hypotension? The initial treatment of orthostatic hypotension is the patient education, right? That is patient education, right? So what is that patient education that you have to do is, you have to advise the patient, or you have to teach the patient that the salt intake of the individual should be increased, right? There should be high salt intake in the diet. And how much should be that? That is around 10 to 20 grams per day has to be taken by the individual. And not only salt intake, even there should be high fluid intake, and that fluid intake, it is at the rate of 2 liters per day. Then you take the head end of the bed. You need to elevate the head of the bed. Right? You need to elevate the head of the bed, and how much should be that? That should be nearly around 10 centimeters. You have to elevate the head end of the bed, and you need to maintain the postural stimuli. That is, the individual should not suddenly get up from supine position. The individual should first turn to the lateral position, wait for a minute, and then sit in the bed with legs hanging down from the edge of the bed. So with hanging legs from the edge of the bed, wait for 1 minute and then slowly get up. And after getting up also, you need to take the support of the wall, or you need to take a support for 1 minute, and then the individual has to go ahead with his work. So that is what is nothing but maintaining the appropriate posture. Right? And at the same time, the garments should be the compression garments. See, what is the purpose of wearing the compression garments by the individual is, this particular compression garments will increase the venous return to the heart, and thereby they will increase the cardiac output, and thereby they will maintain the blood pressure within the individual. Now, and these compression garments, it will be in the form of stockings within the leg. Right, that will be in the form of stockings within the leg. Now, you take the medical management. So, when the measures are inadequate, that means whatever I have taught you, that is high fluid intake, high salt intake, right, stockings. So, if these measures are inadequate, then treatment should be given with fludrocortisone. Right, you need to give fludrocortisone. So this particular fludrocortisone, it is a form of the mineralocorticoid, and the dosage of the fludrocortisone is 0.1 to 0.2 milligrams, should be given orally, and that too daily you have to give this. Right, that is about the fludrocortisone. And this medication, that is fludrocortisone, however, can result in supine hypertension and hypokalemia. The adverse effects associated with the fludrocortisone is hypokalemia, because it has a mineralocorticoid activity. And what does the mineralocorticoids do? Sodium retention and potassium excretion. So the individual will have hypokalemia as an adverse effect. And apart from that, these individuals will also develop supine hypertension. Why? Because this fludrocortisone will cause sodium and as well as water retention. That is the reason why these individuals will develop supine hypertension. And another important drug apart from fludrocortisone will be midodrine. And what is the dosage of the midodrine? Midodrine you have to give 10 milligrams orally 3 times a day. Right, midodrine should be given 10 milligrams orally 3 times a day. And what is this particular midodrine? This particular midodrine, it is an alpha agonist. Right, it is an alpha agonist. So this is what is your midodrine. So this midodrine will also improve the orthostatic blood pressure within the individual. Now, followed by that, treatment of the insulin neuritis. See, on prolonged administration of the insulin, there can be development of neuropathy. Right, on prolonged administration of the insulin, there can be development of neuropathy. This we call it as insulin neuritis or treatment induced neuropathy of diabetes. So this treatment induced neuropathy of diabetes, it occurs occasionally in patients with poor glucose control. Right, so in which group of individuals you will see this? That is in patients with poor glucose control, and it is seen in those individuals where the glucose levels improve rapidly in days or few weeks. Right? Glucose levels they improve rapidly. So even in this group of individuals also you have this treatment induced neuropathy. Now what will be the features of the treatment induced neuropathy? That includes severe sensory neuropathic pains. Right? Sensory neuropathic pains. That will be the features of the insulin neuritis or treatment induced neuropathy. And these symptoms they improve over few months. Right? These symptoms they improve over a few months. That is what is the treatment induced neuropathy. Next, another important abnormality associated with autonomic neuropathy will be erectile dysfunction. Erectile dysfunction can result from neurological, psychological or vascular causes or a combination of these particular causes, right? So it can occur either due to neurological abnormality, or it can be due to psychological abnormality, right? Or it can be due to a vascular cause. Now, what is the drug that we give for the erectile dysfunction is you need to give phosphodiesterase type 5 inhibitors. Right? Phosphodiesterase type 5 inhibitors. And examples of this phosphodiesterase type 5 inhibitors include sildenafil, number 2 vardenafil, number 3 tadalafil, right? So these are the examples of the phosphodiesterase 5 inhibitors, sildenafil, vardenafil and as well as the tadalafil. They have been shown in placebo controlled clinical trials to improve the erections in response to the sexual stimulation. So these group of drugs are very important group of drugs for the treatment of erectile dysfunction. And these phosphodiesterase 5 inhibitors, they are also used in the treatment of pulmonary artery hypertension as well. Now, if you take the dosage of the sildenafil, the recommended dose of sildenafil for most patients is 1 tablet you have to give, that is of 50 milligrams, right? 50 milligrams tablet. This has to be taken approximately 1 hour before the sexual activity. Right? So that is about your sildenafil. And whenever you give this sildenafil, when will be the peak effect of the sildenafil? The peak effect of the sildenafil is at 1.5 to 2 hours. That is after 1.5 to 2 hours. And in some group of individuals, the effect will persist. Right? The effect will persist up to 4 hours. Okay, that is about the efficacy of the sildenafil. And patients with diabetes mellitus using sildenafil reported 50 to 60% improvement in erectile dysfunction. So how much is the efficacy? The efficacy is around 50 to 60% in diabetes mellitus with erectile dysfunction. But what is the maximum dose? The maximum dose of the sildenafil is around 100 milligrams per day. Right, it is around 100 milligrams per day. So that is about the dosage of the sildenafil. Whereas the other phosphodiesterase inhibitors like vardenafil and as well as tadalafil, the recommended dose of both vardenafil and tadalafil, it is 10 milligrams. Right, it is around 10 milligrams. And this particular doses may be increased to 20 milligrams. Right, may be increased to 20 milligrams or decreased to 5 milligrams based on efficacy and side effects. And particularly if you take this tadalafil, tadalafil has been shown to improve erectile function for up to 36 hours after dosing. Right, it will improve it will improve the erectile function for up to 36 hours after dosing. Right, so that is about vardenafil and as well as the tadalafil. Right, that is 10 milligrams. The dosages may be increased to 20 milligrams maximum, right, based on efficacy and as well as the side effects. Now, if you take the adverse effects of the phosphodiesterase 5 inhibitors, so only a few adverse effects have been reported. That includes a transient mild headache can be there, then followed by that flushing, next dyspepsia and some altered color vision. Right, so that these are the adverse effects associated with the phosphodiesterase 5 inhibitors. And with these medications, even there can be development of the priapism. Now, what is this priapism? Priapism, it is the painful erection of the male genital organ. The priapism can occur with these medications, and patients should be advised to seek immediate medical attention if an erection persists for longer than 4 hours. Okay, so if erection persists for longer than 4 hours, immediately the individual should seek the medical attention. That is about the adverse effects of phosphodiesterase 5 inhibitors. Now, can we give this combination of phosphodiesterase 5 inhibitors and as well as nitrates? Let me tell you, this phosphodiesterase 5 inhibitors, they potentiate the hypotensive effects of the nitrates. Right? It will increase the hypotensive effects of nitrates. So that is the reason why combination of phosphodiesterase 5 inhibitors plus nitrates, right, combination of phosphodiesterase 5 inhibitors and nitrates, their combination is contraindicated. Right, this particular combination is contraindicated. That is about your phosphodiesterase 5 inhibitors and as well as the nitrates. So if you combine both these drugs, the individual will have a severe hypotension and then a cardiovascular collapse can occur. Now, coming on to precautions when the patient is taking the phosphodiesterase 5 inhibitors. See, caution is advised for men who have suffered a heart attack. Right? Caution is advised in patients who had suffered a heart attack or who had the past history of stroke or who had the history of life-threatening arrhythmia. So, if these disorders, if it has occurred in the previous 6 months, right, if heart attack or stroke or life-threatening arrhythmias has occurred within the previous 6 months, giving phosphodiesterase 5 inhibitors should be given with caution, right? Because these phosphodiesterase inhibitors, whenever you are giving along with nitrates in case of patients with the coronary artery disease, the individual may develop severe hypotension. So that is the reason why in patients with the ischemic heart disease where you are giving nitrates, you should not give this phosphodiesterase 5 inhibitors. Not only that, in men who have history of heart failure or who have unstable angina, these phosphodiesterase 5 inhibitors are usually avoided. Now, after having discussed about the medical management, so medical management, it is phosphodiesterase 5 inhibitors. Then followed by that, you need to know what are the interventions that can be done for patients with erectile dysfunction. In those individuals where the patients are refractory to medical management, what is that you can do is intracorporeal injection of vasoactive medications. Right, intracorporeal injection of vasoactive injections or vasoactive medications. So whenever you give or whenever you do an intracorporeal injection of vasoactive injections or medications, they will cause the penile engorgement and erection. Right, penile engorgement and erection. And what are the medications most commonly used for this intracorporeal injection? That includes papaverine. Right, that includes papaverine alone, or you can give a combination of papaverine plus phentolamine. Right, you can give a combination of papaverine with phentolamine. And the other important drug that can be given is alprostadil. So this particular alprostadil, it is a prostaglandin analog, and the injections of this alprostadil, these are relatively painless. Right, these are relatively painless, but careful instruction is essential to prevent the local trauma. Right, the problem that can occur is this alprostadil can induce the priapism. This alprostadil can induce the fibrosis. So these are the adverse effects associated with the alprostadil. Now, apart from these injections, intraurethral pellets of alprostadil avoid the problems of injection of the medication. So, one method by which alprostadil can be administered is intracorporeal injection. The alternative method is intraurethral pellets. These intraurethral pellets of alprostadil, they avoid the problems of injection of the medication. So that is about the interventions, that is intracorporeal injection, right? You can give papaverine alone, papaverine plus phentolamine, and then the alprostadil injections. So the other method of treatment of the erectile dysfunction is the external vacuum therapy. External vacuum therapy, it is a non-surgical treatment consisting of a suction chamber operated by a hand pump, right? So it is a non-surgical treatment which is consisting of the suction chamber. Right, which is consisting of suction chamber. And this particular external vacuum therapy, it is operated by a hand pump. Right, it is operated by a hand pump that creates a vacuum around the male genital organ. Right, that is, it creates the vacuum around the male genital organ. So the vacuum which is being created by this particular hand pump, this draws the blood into the male genital organ. Right, this will draw the blood into this draws the blood into the male genital organ, and once it draws the blood into the male genital organ, that will produce the erection. Right, that will produce the erection. Right, so this particular erection, whichever has occurred, is maintained by a specially designed tension ring inserted around the base of the male genital organ. So this particular erection, it is maintained by a specially designed tension ring. Right, it is maintained by specially designed or designated tension ring which is inserted around the base of the male genital organ. And this particular tension ring, it can be kept in place for up to 20 to 30 minutes. Right, it can be kept in place for up to 20 to 30 minutes. This is about the external vacuum therapy for the treatment of erectile dysfunction. While this method is generally effective, it's cumbersome and it will limit its application. Next, the other methodology of the treatment is by the surgical implants. Surgical implants of the penile prosthesis. Right, surgical implants of the penile prosthesis, these will remain an option for those patients in whom non-surgical approaches are ineffective. Okay, so in those individuals in whom non-surgical approaches are ineffective, in them this particular surgical implants are being used. Next, right, so to summarize the treatment of autonomic neuropathy, for gastrointestinal manifestations, that is for gastroparesis, you need to give metoclopramide. and you need to give erythromycin, which will stimulate the motilin receptors. And the other important methodology is the gastric electrical stimulation. And the other thing is you can also do the injection of the botulinum toxin within the pylorus. That is for gastroparesis. For treatment of diarrhea in case of autonomic neuropathy, you need to give broad spectrum antibiotics. And the diarrhea can also be treated by anti-motility drugs like loperamide and as well as diphenoxylate. Then codeine sulfate is another important drug. Clonidine is another important drug. So this is about the treatment of diarrhea associated with autonomic neuropathy. And constipation, how is that you have to treat? That is by stimulant laxatives such as senna. And treatment of the bladder abnormalities. See, incomplete emptying of the bladder will occur, and for that you need to give bethanocol. And the other modality of the treatment is catheter decompression of the distended bladder. Catheter decompression is another methodology by which you can treat this incomplete evacuated bladder. And orthostatic hypotension, the patient education is important. The drugs that we give is fludrocortisone and as well as the midodrine. Insulin neuritis can occur, but that is self-limiting. Erectile dysfunction, you need to give phosphodiesterase 5 inhibitors. And the other method by which you can treat this erectile dysfunction is the injection of the drugs like the alprostadil, and you can also do intracorporeal injection of the papaverine alone or papaverine with phentolamine. So these are the various injections. And the other methodology is external vacuum therapy, which is a non-surgical treatment. And lastly, surgical implants of penile prosthesis remain an option for those patients in whom non-surgical approaches are ineffective. So this is about the treatment of autonomic neuropathy, and this completes the discussion of this very important topic, that is autonomic neuropathy. Thank you very much.